I like it when the economics and infrastructure group is more seditionist than the patient and community group. That's a good sign. I thought we were seditious, but it turns out not quite as much. We had two case studies. We had very lively discussion. One was, it sounds like the same, although from a slightly different perspective, as the one that um, Susan just described, which was the community intervention one. And there was a question sort of about the patient and community perspective on that. And the other one was involved an individual patient. It turns out it was actually based on Malcolm Cox's wife, which happened to her the week before. It was a visit to the ER by a marathon runner who had some knee pain, and before even he or she was seen, there was a determination there should be an X-ray, just in anticipation of seeing the orthopedic surgeon or the orthopedist. And the patient tried to decline that, saying that she knew there was no broken bone, and she was cajoled and persuaded to have the X-ray because otherwise insurance might not pay for the impending MRI. To be sure, there would be, of course, an MRI. So our conversation kind of was revolved around how patients can try to have power and influence in the healthcare scenario, how that doesn't work, both on an individual level, that case, and on a community level, the community intervention case. So in the three slides, which I'm waiting for them to come up, the three last slides, and we don't need those. Okay, so the first question, can diverse health professionals be held accountable for their collective actions by patients and society? The first answer that one of our members gave was no, because you actually need a collective sort of group to take collective action. And the idea was that that's kind of why we're here. If we had collective action, we probably wouldn't need interprofessional educational programs quite so desperately. So in one sense, we don't have collective action, so it cannot be, we can't be held accountable for it. The yes answer, however, if we presume, for the sake of discussion, I feel like an economist now, if we presume that we have accountability or collective action, then there would be three ways, it seems to be, that patients and society could hold accountable. One is by using community group assessments. We had a great example given by a member of our group from India, where there are patient groups that assess healthcare delivery institutions and go around and assess all aspects of them. So rather than have experts come and say how you're doing or not doing with regard to delivering care, patients as a group do it and see different things, obviously, and understand different things, and community members also. So we had questions about accountable to whom and who does the accounting, and based on what, in order to be accountable, you have to have sort of a shared vision of what the goals are, because you have to be accountable to something, right? It requires a lot of transparency. That came up for us quite a bit too, the notion of transparency. So I think that's a cross-group theme right now. Transparency allows mutual understanding of the challenges that all the players face. We had a great conversation about how when patients are involved in assessing programs, they begin to understand how difficult it is for healthcare professionals to deliver healthcare, and to do it effectively. They begin to understand the challenges that the community brings, and that individual patients as members of that community bring, and so become both more compassionate and potentially begin to sort of get the process of absorbing some of the responsibility, both for using care effectively and ultimately, of course, the big kahuna, right, for their own health, because they begin to realize that this frustration physicians and other healthcare professionals have with trying to deliver care to people who don't care for themselves is sort of the ultimate challenge, I think. So we had a great conversation about that and about how valuable that could be, having patients engaged in assessment. The second big point that was made was that there needs to be, patients need to become knowledgeable about the really difficult things about healthcare, like, for instance, that a third of it is wasted and harmful, according to the Institute of Medicine, and need to be able to speak truth to power. So a member of our group basically when he goes into his physician's office. He says a third of healthcare is wasteful and in fact harmful. Is what you're giving me today wasteful and harmful or not? It's a place to start, if you ask me. Nothing like early adopters and thought leaders, right? Um, the other point that was made in that conversation was connecting people who are not quite so powerful to powerful partners, so that all in this room is full of powerful partners. And if each of you was connected to, half a dozen patients and you sort of coached them on how to approach healthcare situations, that's sort of the beginning of a movement in this direction, I think. And the third point was to start a conversation at local and regional levels to build momentum and agreement. Again, this point about what we're trying to do, where we're trying to go before starting the national dialogue. And yesterday we had a kind of a aspirational point about, getting together a whole sort of national conversation, or maybe that was in our group actually, about having a national conversation about mission. And I think several people voiced what I was sort of feeling, which was kind of this giant sigh saying, about that national conversation. Easy for you to say, you're not from here, But I think we can have local and regional conversations about what our goals are, and that point was also made in our group that local and regional conversations are the biggest hope for us at this point. The next slide was, can diverse health professionals hold each other accountable for decisions made collaboratively? We too had a very strong conversation about shifting from the culture of blame to a culture of safety and mutuality. There will be barriers, organizational, legal, and I would add financial barriers. I think the sort of elephant in the living room we keep coming up against and have sort of said it a little bit here and there is, if every system is perfectly designed to get the result it gets, then our system must be designed to produce healthcare at a profit. And that sometimes I think doesn't mesh well with cultures of safety and other and less care and abolishing waste and so on and so on. Mutual respect among professions, they're not whole unless they're together. So this notion of a really nice conversation about educating students across disciplines together from the very beginning, so that they understand on a fundamental level, we understand on a fundamental level that we need each other. That we add value to each other. I think the video this morning was a really strong example of that. I was caused to think watching that video today that there's even a more fundamental sort of psychological thing going on, if you'll pardon me to, be a jack of all trades like all lawyers are and pretend like I know something about psychology. But it does strike me that it's lonely to practice healthcare, especially if what you're trying to do is care for somebody who doesn't care for themselves very well. That strikes me as very lonely. And if you can have any other person who's really joining you in that, that seems like a powerful link. And almost you could just put two people together and let them figure out their own curriculum if they could just know they would be there at the beginning and the end of this process together. I think there was a strong point about rethinking the scope of practice from our current sort of individual, I'm responsible for this, you're responsible for that, he's responsible for that, to the notion that our team is responsible for this outcome, and to assess and evaluate learners as individuals as well as members of teams. So both assessing both individual, the medical performance, the nursing performance, and so on, to assessing the team's performance. And the third major area was, of course, organizational behavior, delivery systems, and academic medical centers and organizations and schools, medical schools, nursing schools, and others need reform, with the fundamental sort of notion, this is a real synthesis of a much richer conversation, how we are treated influences how we treat others, and that's a fundamental challenge, I think, for our system. Finally, what specific measures attributable or an attribute should organizations and training programs exhibit? The change in culture, putting patients at the center and letting patients lead and guide us. Education and training, that it's about joining in authentic work, not just about standing around and singing Kumbaya together, but about saying, uh-oh, we have a serious problem here and we need all hands on deck. And we need to respect each other across that. Integrating, the point was made earlier, faculty also from different professions, and integrating patients as teachers and learners in the in the equation. I don't remember what contract concept means. Oh, right. Yes, I was, before it was said by our lawyer on the screen yesterday, I was talking about how one of the attributes of contract, essential attributes of contract, is something called consideration, which the gentleman said yesterday, but both people have to offer something of value, and generally speaking, in order to be a valid contract, it has to be of equal value. So we have to give some thought to what is it that patients bring to this equation, and I think it would be probably difficult for most people in this room to articulate what patients bring to that aspect, to their side of the social contract, what society brings. And I think it'd be important, other than, we promise to treat you with respect and give you a monopoly in the business. I think if it's going to be a social contract, it probably needs more than that. And finally, 3 organizations. Change requires wisdom and courage to upend the expert paradigm, the model we have, the dominant model of experts and people who aren't. One way to do that is to really take in and understand that patients actually have expertise that's actually mission critical to what's going to happen in the room. And if we sort of took that in and really realized that, that's maybe the beginning of something patients have to bring into the social contract and into the care contract. Collaborative leadership, engaging, again, patients and other disciplines all the way across the leadership, panoply, that's the wrong word. But engaging patients and other community members in the actual leadership of academic institutions, academic medical centers, and other organizational care delivery centers. And that CEOs must be accountable for making contact with communities. CEOs at the highest level. There must be accountability for linking communities with health delivery organizations. So that was our group's conversation.
Very fine. Mary Jo Keitzer, Group 4.